When Michelle and I approached Heidi about doing a talk on the state of the science of blood-based biomarkers for Alzheimer's in oncology, Heidi said that might be one slide. So we thought instead that we would really have a conversation about how the availability of blood-based biomarkers might change the practice of an oncologist and change the patient's lives. So I'm going to let Heidi introduce herself. I'm a geriatrician. I'm the chief of geriatrics at Wake Forest. And Heidi is even more erudite than I. So.
Thank you for that. So I'm Heidi Klepin. I'm a geriatric oncologist. So I have been at Wake Forest for a very long time. I trained in geriatrics first under Dr. Williamson. So I thank him, as do my patients frequently. And many others here, spent another year in geriatrics, kind of just taking care of patients and being a geriatrician, and then had decided that I wanted to bring geriatric care into oncology. So that was back in some time frame. That's a long time ago. But we're just going to say 2003.
Not that long.
2000. Well, according to all the residents, that's a long time ago. Had been inspired when I was in internal medicine here, caring for patients on our leukemia service, that I really loved the patient care aspect of oncology, but I didn't really resonate with the oncologist's approach to, we have this cancer and here's what we do for this cancer. And that's kind of the end of the guideline-based story. And then we would care for patients who were 70 plus years old with aggressive malignancies, and really just applying either the same approach we did to younger patients, and it didn't always go well, or, at other centers, they weren't treated at all just because of their age, one or the other. And, then when I went into geriatrics and, learned about how to approach patients in a more holistic way and using geriatric assessment and the connection between clinical care and research in the geriatric center, as a fellow, as I was training, you saw sort of that bench to bedside, PhD scientist working with a clinician who said, this patient in my clinic has this issue. Here's how we might approach that from a research perspective. That really inspired me. And I decided, I think I want to bring this over to oncology. And at the time, there were very few people doing geriatric oncology. So when I approached my boss, who is our division chief in oncology, and said, I want to come back and train in oncology and be a geriatric oncologist. And he said, well, I don't necessarily need one of those. I need somebody to take care of breast cancer patients and colon cancer patients. He's like, but I worked with Bill Hazard and I understand the importance of geriatric specialized care in oncology and all of our other subspecialties. So, and he was strategic enough to know that if no one else is in the field yet, you've got a shot. So if you're there early on, that I had a better chance with respect to some of the research ideas that we had. So that's kind of a long story to say that I've been in geriatric oncology now here at Wake for a number of years, and been able to pursue a lot of my research interests in addition to caring for patients in my clinic who are all 75 and older. So I designed a clinic where I said, I just want to see older patients and focus on, more vulnerable and frail patients, and not necessarily just on a tumor type, although I will say I treat a lot of breast cancer patients because the surgeons all refer to me. But I've been able to sort of focus a lot of my earlier research, really, again, inspired by our work in the Pepper Center in particular, on looking at how geriatric assessment as sort of a collection, essentially, of performance-based biomarkers, if we want to look at it that way, including gait speed, short physical performance battery, cognition assessment, as well as all of the other components of a geriatric assessment, and test that in the setting of oncology care. Can we do this? And I focused on acute leukemia because we were an acute leukemia center here initially, and most people in the field said, this isn't going to matter. It doesn't matter what their gait speed is, for example. They have acute leukemia. They're going to die from this. We have to give them intensive therapy now. It's the biology of the disease that matters. So we were able to show that actually no, that in that setting, if we conducted geriatric assessment at the bedside in the hospital, that it was the short physical performance battery, so their objectively measured function, and cognition assessed at that time. We used the 3MS. So this was back 2000. 2,000 years ago. No, long ago, 2011, I think, is when we finished the study. And those two markers, it wasn't what patients said they could do at that time, actually, because the disease is so acute that their function changed very quickly. And so they're remembering how they were 3 to 6 months ago, and they were doing great. But it was how they performed in the moment before their induction chemotherapy was given that mattered. And none of these patients had a diagnosis of dementia. So they were all patients who were screened by the oncologist to say, these are the fit older patients that we can give intensive therapy to. About 20 to 25% in our study, and this has now been shown in other studies, had met the threshold for impairment on the 3MS. And that was independently associated with survival, beyond the biologic factors and independent of the objectively measured physical performance. So cognition mattered, physical performance mattered. And that's now been replicated. And you may not know this, but another group in South Korea did the same study several years later, intensively treated older patients with AML, and showed again cognition using the MMSE and the SPBB were the two factors associated with survival and toxicity. So kind of validating at least those observations. And that was really kind of transformative in the field of hematologic malignancy, because they were not on board with these things matter. It's our therapies, it's the biology. So I'll stop there. You probably wanted me to say less.
No, I didn't. I
He's like, no, I brought you here to talk.
No, I think what you just said is a lot of times when we think of, I don't know, maybe this is specific sometimes I think to the Alzheimer's dementia world. It's not like this is the only biomarker that's ever been in existence. So you have just said there's a functional biomarker. Function is a biomarker. And so we have a disease here that, and we have an expert here. Heidi's modest. She's a Beeson scholar. She's board certified in 2 specialties. One of the only board certified in 3. Sorry, hematology. 4. I keep
just saying. I recertified.
Just 4.
It's really painful.
Yes, you should say all that. So 4. But we have models for some of the things we're talking about, and so I wanted really Heidi's expertise to bring that into this conversation. So based on what you just said, how now do you incorporate the biomarker of physical and cognitive function into your planning for a chemotherapeutic agent for a patient, whether that's breast cancer or a hematologic malignancy? How do you do that now? How does it change your planning and conversation at the beginning with that patient?
Sure, yeah. So I'll talk about kind of how it's influenced me. Again, I'm biased because I trained in geriatrics. So when I opened up my clinic, even before we had data from trials, I knew this was better care, right? So I was conducting a geriatric assessment.
Educated, not biased.
Educated. I was educated. So we did geriatric assessment, and then we were working on trying to prove what we thought was obvious, right? That this is going to show, a benefit for patients. And so what I do in my practice, so I conduct, a new patient visit. So I'm seeing someone this afternoon. I have a clinic this afternoon. I'm sorry. But I'm seeing a patient this afternoon who was referred to me who actually does have dementia, new diagnosis of an advanced stage breast cancer. And, as part of my initial assessment, I would conduct, in addition to reviewing all of their cancer history, an abbreviated geriatric assessment. So this isn't a multidisciplinary. I don't have another actual geriatrician with me. I'm still certified, but obviously I'm not Heather Whitson. I don't practice geriatrics every day. I practice this in the context of oncology. So we conduct, sort of survey-based, self-reported assessment of ADLs, IADLs, emotional health, psychological health, polypharmacy review. I do have a pharmacist with me, nutritional status. So all of those things using, I previously had a series of assessments, all validated measures that I had put together that I was using, and then in addition, the performance-based measures of the short physical performance battery and a cognition screen. We do that as part of the physical exam. So some of it they fill out before I even come in the room, and then usually the SPBB and the cognition screen I do myself, or I train if somebody's with me, I'll have them do it under my guidance, because I really want to see that. And I want to see how, because the score sometimes on the cognition screen, how patients sort of respond as you're doing the assessment is valuable. And then I tell people that, because a lot of times they're taken aback, like why, especially the cognition screen, that's the one thing that people are a little bit, they're coming in to see an oncologist and they say, I want to screen I want to screen your memory and attention. As part of my physical exam, they get nervous because they think I might not give them treatment for their cancer because they failed the test. So I have to, up front say, I want to know holistically, I want to examine as much as I can so that I know as much as I can about you as a person so I can personalize the treatment to you. This is just as I want to personalize therapy to the biology of your disease, I need to know as much as I can about you so that we can make a decision together. But you kind of have to, really preempt that because some people get, and of course everybody gets flustered. And so you have to take that into account. I'm pretty sure I would fail my cognition test if I were in like a stressful situation. That and Heather menopause, so all these things. But I then use it to help guide our discussion. So if it's a curative treatment setting, and we're talking about, for example, chemotherapy, then those elements are helping me interpret your risk of side effects, your risk of tolerability. And then we kind of walk through in that setting, if I have a patient with multiple vulnerabilities and we're talking about giving an adjuvant treatment, which basically means let's say resected breast cancer. So your risk of recurrence is maybe 50%. And I had patients like this regularly, 80 years old, we do their assessment and they have multiple vulnerabilities. And I could say, your risk of recurrence is high over the next 5 to 10 years. So, because 50% is high. But if you have cognitive impairment and functional impairment and multiple chronic conditions and some challenges with social support, your risk of chemotherapy toxicity is 80 to 90%, serious toxicity. And I can make your quality of life worse in the short term. And we're not sure you need this treatment, because there is a 50% chance you're cured. And so it informs the conversation of how I recommend treatment, whether or not I recommend it or don't, or a lot of times in the middle, how we talk through what matters most to you.
So you're using those functional biomarkers as sort of a stop-go. Do you also use it as a way to alter the intensity of your therapy sometimes? Do you do that? And then we're going to talk after this, I'm going to ask you about during therapy, do you also assess for these and it changes your plan? And then, because all these have implications for a biomarker later on down the road. So you want to talk about first about, do you alter the intensity of therapy based on some of these findings?
Yes, and I will say that, in the last 15 years or plus that I've been in the field, many people have done larger studies, and I would say contributed much more than I have to the field, including people like the late Arthi Huria and Supriya Mohile, who've designed much larger studies to be able to show repeatedly the value of doing geriatric assessment to help predict outcomes, to give us more information to guide decision making, to the point where in 2018, the American Society of Clinical Oncology brought together a group of experts to put forth the first guidelines for older adults with cancer to say all older adults starting chemotherapy should have a geriatric assessment. So that was a guideline made by our big oncology society back in 2018, based on mostly all the observational data that showed how valuable it can be in sort of that informed decision making and recommending supportive care interventions based on the geriatric assessment. We didn't have outcome data yet. So just this past year, we now have 6 randomized trials, most of which show positive outcome for patients getting geriatric assessment at the time of starting chemotherapy in particular, and that improves their outcome. Because that's what oncologists would ask me, like, that's great, Heidi, you're doing a geriatric assessment, but how does it change the outcome of the patient? Show me the data. So now we have data from randomized trials that says if a patient gets geriatric assessment and their oncologist gets the data, so just give them the data, they're going to make a different decision about treatment intensity, for example, or make referrals around their supportive care, and treatment toxicity is decreased. And the number needed to prevent harm in one of the larger randomized controlled trials was only 5. So that's like a huge, absolute risk reduction, just for getting geriatric assessment data. So the guideline now says all older patients getting systemic therapy should have a geriatric assessment, which includes these performance-based measures. The challenge is it's not being done. So the next issue is implementation. But one of the largest trial that really contributed to this data, showing a benefit in decreasing toxicity, I think addresses your question, full circle, which is these were all older patients who had non-curative cancer. So they all had advanced cancer. They were 70 above and had at least one vulnerability. So kind of more vulnerable older adults. What do you do in that setting? And so the clinics where it was a clinic randomized trial, when the clinics who had geriatric assessment data, that just a report, that said your patient has these vulnerabilities. Consider basically, if they fall, and falls, as this was mentioned earlier, it's consistently a risk factor for bad outcomes in cancer care. So if your patient falls a lot, these are some practical things you should be doing, and so kind of giving those bulleted practical recommendations. That degree of an intervention resulted in significant decrease in toxicity. And when you look at what was done, what's the mechanism of the decreased toxicity, one of the outcomes that they reported in the primary study was that the oncologist in that setting made a choice to dose reduce up front, because you're giving chemotherapy in a non-curative intent setting, and your goal is certainly to do no harm while you're trying to provide disease control and quality of life. And so a standard approach is to, as oncologists would always say, go low and go slow, right? So they dose reduced by about 25%. About 2/3 of the oncologists did that in the intervention arm. And it improved toxicity, and it didn't impact survival, meaning they lived just as long and they had less toxicity. Because to an oncologist, they would say, well, I can reduce toxicity by giving no chemo, but the cancer's going to rage, right? But they showed that that wasn't the case. And so I use that, and I teach that to our fellows to say, you've got great randomized controlled trial data now to say, if you assess patients in this setting and have vulnerabilities, you can make a different choice. You can dose reduce, or in the adjuvant setting, you can choose the shortest, least toxic regimen. So that's a long answer.
No, that's good. So I'm going to change channels a little bit to talk about these blood-based biomarkers for dementia and cognitive health, and use them and talk about them in the context of something called chemo brain. Now, many people are not oncologists in this room. Can you give us just a short answer on chemo brain, what it is, its longevity, so to speak, and then then I'll just go ahead and ask you to also say, how could you imagine that blood-based biomarkers for cognitive health might influence assessing risk factor for chemo brain?
Yes. Disclaimer, I'm not an expert in chemotherapy-associated cognitive dysfunction, but in general, it is a well-described phenomena, particularly in breast cancer patients. That's where a lot of the literature has come from, where patients, and not specific to age, actually most of the data is sort of from middle-aged patients who self-report memory and attention as sort of primary symptom complaints after receiving chemotherapy. And, some of the studies have shown that, and this is in breast cancer in particular, up to 50% in the observational studies, up to 50% of patients have reported some symptomatic change, particularly in those two domains. It's described, it doesn't seem to be a phenomena that completely resolves. So if you were to interview, and there have been studies that look at, breast cancer survivors 5 years out, you still have a significant proportion of those patients saying, I'm still having these symptoms. Things are different now. And again, attention and sort of short-term memory are the main two complaints. What's interesting is that, it's still, there's a lot of research going on to try and understand mechanistically what's going on, because obviously that relates to biomarkers and, of course, what you do to intervene. But what's very clear is that when you look at sort of self-reported cognitive complaints, which are quite prevalent, that they don't necessarily correlate well with neuropsychiatric testing, so the objective testing data. We see this in patients, because a lot of my patients have these complaints after treatment. And if it's bothersome to them, I'll send them to our memory care clinic in the Sticht Center for a further evaluation, and they do well on their sort of battery of objective tests, but they're still having these complaints. So there's a lack of correlation between the two, at least at a population level. I don't think they've drilled down well enough to say, well, where are the pockets of folks who actually do correlate, right? Because that's slightly different pathology. And the correlation between imaging measures is also not very high with the self-reported symptoms. And so, understanding what is mechanistically happening here is not clear. That there are a lot of, hypotheses and multifactorial, but it is a phenomenon that's well described, at least symptomatically. It doesn't necessarily resolve completely over time, and it affects younger and older patients. And I think the question about are older adults more susceptible from the larger cohort studies, it's not clear. Some said yes, some said no. I would say older adults are underrepresented, and certainly older adults with multiple chronic conditions are underrepresented in all these studies. So I would say that you're going to be at greater risk if you have a higher proportion of patients already with MCI potentially, but the current data isn't necessarily showing that there's clearly an age. And again, it's been heavily biased by younger breast cancer cohorts that have contributed to a lot of the data. But I think to follow up on that, so this is a question that comes up for, I think, all oncologists, and certainly in my practice, a lot of my patients, I see mostly octogenarians, because I'm 75 and above, so most people in my clinic are in their 80s. And I've had many conversations with what ultimately I determined was a fit 80-year-old. They have an aggressive, let's say, triple negative breast cancer it's been resected, their risk of recurrence is high. I do use e-prognosis, which I think overestimates everyone's life expectancy, but it gives us a ballpark. I think your life expectancy is potentially close to 10 years. If this recurs, it'll be in the next 5. This is the biggest threat to you. I think chemotherapy is indicated. And we have this conversation, and they weren't necessarily expecting me to say that. And the first thing that a lot of patients say when I ask them, well, what matters most to you? And they'll say, it's maintaining my cognitive function. And how likely is it that this chemotherapy is going to cause cognitive dysfunction over the next 5 years? Because if I have a high risk of that, I don't want to take it. I'll take my chances with the cancer coming back. And this is heard again and again. And we don't have, for patients who don't already have dementia, we don't have data to tell us who is at higher risk. And I know that this would be research before practice, but that's a setting where if we had some kind of biomarker, whether it's blood-based, perfect, because nobody's going to do CSF, right? But to be able to identify those patients who are at higher risk for this outcome, that would change decisions in that setting right off the cuff.
Yeah, I know that certainly people who have cancer chemotherapy have a higher incidence of dementia later in life. So what I'm hearing you say, hypothetically, if some of these blood-based marker tests could differentiate those people who are truly at an increased risk, that would be very helpful. The other thing is certain agents are more toxic than others, I've heard, Heidi. And so that also might influence the choice of agent as well as the dose, I'm assuming. Is that correct?
Yeah, no, that's correct. And I think, so the literature, of course, would suggest, and we see this, it's just logical, that the more intense and the longer duration treatment you get, the more likely you are to have toxicity. So we would make changes. And we are, increasingly, we've seen this in lung cancer, but in a lot of other disease settings as well, where you have more and more options to choose non-cytotoxic chemotherapy. So immunotherapy for lung cancer, game changer. But there are still indications for doing combined immunochemotherapy. And so you're then making a choice of, do I give you sort of the best combined treatment that is likely to give you the longest term benefit with your cancer, or is your risk of that high enough that we want to just go with single agent immunotherapy up front and, basically minimize the risk that, not that we have data on immunotherapy either, but it's not as well described that there's a sort of with PD-L1 inhibitors anyway, we don't see a lot of cognition issues. We could open up a whole nother can of worms and talk about CAR-T and BiTE therapy and all of the ICANS, neurotoxicity, but that might be beyond the scope.
We're almost beyond that right now. So, no, I think we do want to have just time for a few more questions, but I mainly wanted us to talk about this to see that there are implications for disease management outside the management of dementia. And oncology is a perfect example of that. We use renal biomarkers in oncology renal biomarkers like EGFR to decide, can we actually follow this patient using this agent, or we might use a different agent, right? We do this in antibiotic therapy. So I foresee a day possibly when these biomarkers might help us better select therapies to increase the to prolong the functional independence of older people. That's our goal. One last question is I think that geriatrics is a great place for personalized medicine. I think it's the best place because the heterogeneity is so much greater in older people. So I'm assuming, I asked Heather this question, there are some people in their 60s who you would not give the treatment that you might give people in their 80s. Is that right? I know the answer already, but.
Yes. Yeah, no, absolutely. And that's one of the things that, that's
Right.
what we see, that we see 70-year-old patients who have multiple chronic conditions and functional impairments. And so it's really about the person, it's about their phenotype, it's about their goals, it's not about their age. You see that much more, in the 70 and 80 plus age group.
Questions? We have like 1 minute for questions.
Just
All questions for Heidi.
about the microphone. I don't want to get on the record here, but
No, I want you on the record.
So I know cognition is the focus of the meeting, but from practice, you don't practice in this country, then younger, say 60-year-old peripheral neuropathy, this is not coming up in discussion as a primary concern and use this as a dosing measure, because I think that's actually where guidelines are going now, to understand treatment intensity, selection of treatment as a function of this. I mean, to me, tingling my fingers and my foot would be more important. I'm not saying this is the same for everyone else as precision medicine as well, but do we need the personalized medicine approach to see what's really relevant at a given stage of the disease and for quality of life? I mean, I know this is focused on the cognition here, but taking this back into the holistic.
Yeah. Andreas, I have an 89-year-old who has colon cancer who actually had to fight to get a colonoscopy. A very, very active person. Very highly active. He's had it now for 2 years, undergone chemotherapy, and his main complaint is the neuropathy. He's doing really well. Still going to Wake Forest basketball and. Did you do that?
No. Like, you're done.
I'm not on the record either. That's right. Anyway, he's going to many activities, but his biggest complaint is, wow, I'm starting to have neuropathy, and I'm worried I'm going to fall. He just turned 90. And he's driving and everything. So again, he's a great illustration of the case that Heather talked about. It's not an age thing, but for him, that is as important as his cognition. And we can.
Yeah, and I'm not saying we should limit people in their choices.
Right,
That's
right.
what I'm saying.
I don't know if these biomarkers even predict neuropathy.
Yeah, they do.
Yes.
It's a trial ongoing.
NFL. So that's already an area of great interest, right? Because we know that that's an issue with certain meds, but to have better markers to be able to predict it would be important.
One question?
Oh, sure.
And Nicole, if you want to ask one, and then everybody can have a break. I guess I do have a question. So you've talked about the effects of cognition and thinking about personalized medicine, but then with these blood-based biomarkers, do you think it's going to make a difference if we tell you that they have Alzheimer's pathology versus cerebrovascular pathology versus down the road Lewy body pathology? I mean, is that being thought of at all?
It might be, somebody might be thinking about it. I'm sure there's a smart person thinking about it. I think, at the bedside, what matters most is the clinical consequence of that, because my patient's not going to care what the mechanism was that resulted in their cognitive dysfunction, but just if we can identify biomarkers that are associated with that risk, that's what they want to know about. And then, of course, the mechanisms would come into play when we're trying to prevent, like you mentioned, I think the UPBE trial, which was not a trial focused on cognition, but the REMEMBER trial, which was run through the Wake Forest NCORE research base, which was a large study looking at using donepezil to try and treat chemotherapy-associated cognitive dysfunction in women, in female breast cancer survivors, not necessarily older. They only have a subset of the true older, but they were working on this mechanism, right, that you presumed donepezil would have a positive impact. The study was negative. It was just published like right now in the JCO. But I think that's where understanding, which of the mechanisms might feed in, that's where that would come into play. Because if we can do something differently to prevent, this is what I always say about geriatric assessment, because oncologists will say, well, I just have this information. Now I just know more stuff I don't want to know. And it's like, well, no, you need to know it because we need to do things differently with the information. And I would say that would be the same thing. It's not just about our management then, but guiding these interventions, right? There are intervention studies now looking at intervening to improve chemotherapy-associated cognitive dysfunction, but they're not guided necessarily by a great understanding of the mechanisms that underlie it. So I don't know, going rogue now.
Right.
Thanks.
Nicole?
I'm thinking about your breast cancer example, and I think even the sort of 5 years out, still these subjective complaints that maybe don't even sort of seem to be validated on objective measures. But I mean, there's a lot of genotyping that gets done, right, for breast cancer patients in particular, at least I think. And so is there anything there with regard to sort of, sort of APOE sort of status and sort of implications for cognition long-term sort of after chemotherapy?
So not in clinical practice, research certainly looking at risk APOE and its association with chemotherapy-associated cognitive dysfunction, but that's not, it's not been sort of validated as a consistent risk factor, so it's not made it to clinical practice. And then all the genotyping we're doing are looking for, BRCA and inherit, it's basically your breast cancer risk and your cancer risk, because those are clearly validated in this setting now. I was just going to mention two other things, because I know you're going to take the mic away from me. But one is just that, a lot of patients do ask, like, when they do develop chemotherapy-associated cognitive dysfunction, how likely is this to progress, right? And it's not clear. Like, a lot of people, like what we tell people right now is, like, it doesn't necessarily progress. It just, sadly, it might just be there. But then, of course, other things may be happening to them where they do have progression, and to the interaction between the two, it makes sense that if you have some underlying pathology and then you get this other hit, right, that your slope of cognitive, decline changes, but we don't yet have markers to help us predict that, right, trajectory of change. And that's a common question. Like, what do I need to expect? Am I going to be like my mom who was in a nursing home? Not my mom, but the patient's mom, let's say, with Alzheimer's, classic Alzheimer's, or is this different? And so I think that's important. And then, Heather, you just, you inspired me when you were giving your talk about, I was thinking about sort of this outcome, predicting the outcomes in this case. But we do see a lot of patients who have dementia, right? And that's more of the discussion here. And I recently had a patient where, the patient had dementia, but was still living at home independently, independent in her ADLs, propped up with IADLs, happy, her quality of life was good, but she clearly had dementia. She came in, she had a locally advanced breast cancer that was already kind of eroding a little bit, and she already had a wound, and that's surgery. Like that, your first step should be surgical resection. She didn't have advanced disease, but she and her daughter, they wanted to avoid surgery. Goals of care were, we don't want surgery, we want some other strategy. So it was ER positive, so we went with primary endocrine therapy just to control it. It responded for a while. And then a year and a half later, and she had good quality time, and then a year and a half later, she's no different from her dementia, but her cancer is now different. And it is now rapidly progressing locally, and we had to finally send her to surgery, and it was too late. It had started to, and it's all progressing on the skin, and so she missed her window, and maybe that couldn't be avoided, but I'm just thinking about, in my case, I was thinking, obviously these were her goals, and I wasn't going to push her in a different direction, but we also would have thought that she would have had some cognitive change over that time frame that made you feel like, yes, the cancer probably isn't going to be the thing. And yet it is. And so I just mentioned that to say, like, we do see a lot of patients with dementia, and we don't really know as oncologists, like, and I should know better. I'm a geriatric oncologist, but I don't spend my time, thinking about dementia at this point. That's not my focus, and certainly other oncologists don't. And so how do you predict which patient with cognitive impairment or dementia is gonna, should be treated with a more standard approach, right? Because there's an over-treatment, under-treatment issue. And so I just bring that up because that's another setting where being able to better predict the, what's going to happen to their cognitive function would be helpful. So, yep.
Great. Well, thank you very much.